Hello, everybody. This is Jeanette Partuccio from Accelero Health Partners. Thank you for joining us today to discuss the AAOS Surgical Management of Osteoarthritis of the Knee, an evidence-based clinical practice guideline. We're going to get started here momentarily, so please bear with us. Thank you.
So today we will be focusing on our discussion on the recently released evidence-based clinical practice guideline from AAOS. Describes the surgical management of osteoarthritis of the knee. It was developed by an AAOS physician volunteer guideline development group based on a systematic review of the current scientific and clinical information and the accepted approaches to treatment and/or diagnoses. So let me start with how the guideline was developed. The clinical practice guideline is based on a systematic review of peer-reviewed articles published all the way back from 1966 to January of 2015. And this only included those patients over the age of 18. The guideline development group opted to include more contemporary literature to make its conclusions as relevant as possible to the current practice of orthopedic surgeons. The clinical practice guideline is not intended to be a fixed protocol. Some patients may require more or less treatment or different means of diagnosis. It was funded by AAOS without any additional outside funding, so that should help reduce any bias. Once the final draft was completed, the guideline draft underwent peer review for additional input from external content experts. After the draft was modified in response to peer review, then there was a 30-day period of public commentary. The final guideline was then approved by the AAOS Committee on Evidence-Based Quality and Value Committee, the AAOS Council on Research and Quality, as well as the AAOS Board of Directors. The purpose of this clinical practice guideline is to help improve treatment based on the current best evidence. Current evidence-based medicine standards demand that the physicians use the best available evidence in their clinical decision-making. To assist them, this clinical practice guideline consists of a systematic review of the available literature regarding the management of surgical management of knee osteoarthritis in adults. As I mentioned, the AAOS staff reviewed all of the literature and subsequently wrote the following recommendations. It was based on a rigorous standardized process. The guideline is available, as you see above, at www.orthoguidelines.org. Not only are evidence-based guidelines listed here, but also appropriate use criteria. So let's get into the complexity of how these recommendations were defined. We will first review these recommendations and their rating systems. Evaluating the quality of evidence is only a stepping stone towards arriving at the strength of a guideline recommendation. The strength of the recommendation also takes into account the quality, quantity, and trade-off between the benefits and harms of treatment, the magnitude of the treatment's impact, and whether there is data on critical outcomes. The strength of the recommendation expresses the degree of confidence one can have in a recommendation. As such, the strength expresses how possible it is that a recommendation will be overturned by future evidence. It is very difficult for future evidence to overturn a recommendation that is based on high-quality, randomized controlled trials that show a large effect. It's more likely that the future evidence will overturn recommendations derived from a few small retrospective comparative studies. Consequently, recommendations based on the former kind of evidence are given a high strength of recommendation, and the latter evidence are given for a lower strength. The development of the strength of recommendation, AAOS staff first assigned a preliminary strength for each recommendation that took only the final quality and the quantity of the evidence. Recommendations were approved and adopted in instances where a simple majority, or 60%, of the guideline-developed group voted to approve. The guideline work group considers the procedure of interest and comparison procedure when recommending or not recommending a procedure for clinical use. If the procedure of interest results in outcomes that are similar to the comparison procedure, the work group may recommend both procedures due to no statistical change in the outcomes. So as we look at this slide, you can see that a strong evidence is a visual representation of 4 stars as compared to a limited evidence of 2 stars. So as we go through this information, we will be sharing with you the strength of any of these recommendations. So as we get to this graph, it's important to understand this was provided by AAOS. you can see the number of quality of the studies that were reviewed for each recommendation. As you can see, some recommendations came out of many articles, while others were developed with just a few or even one article. As an example, when you look at the one with 27, the periarticular local injection, there were 27 high-quality studies being utilized as compared to delay in total knee arthroplasty, where there was only 2. So now that we've given you a frame of reference for how these guidelines were developed, I'm going to turn this presentation over to Tim, where he can start going through some more specific recommendations.
Perfect. Thank you, Michelle. Good afternoon, everyone. Appreciate your patience with our technical problems, but I think we're moving quickly to the next piece where we're going to cover the perioperative recommendations. Want to start off by asking your opinion, your experience. We're going to ask a poll question. So as Jeanette pulls up the polling function, each one of you put your hands on your buzzards, answer the question, are you currently using tourniquets on all your total knee replacements? And now is when the Jeopardy theme plays. Looks like we're getting some in. Give it one more minute or so. So Jeanette, can you interpret the responses for us? Looks like we're closing now. So is that 44% are saying yes, currently using, thank you very much for opening that. So 44% of the respondents said yes, currently using tourniquets on all your total joint replacements. Only 6%, or 1 out of 18, said no, and there are several, maybe 17% responded that they were unsure and did not know. Okay, excellent. So we're going to move to the next slide. Let's talk about what the AAOS report had to say about tourniquet usage for these 3 categories: blood loss reduction, pain reduction, and postoperative function overall. As you can see, they had some good quality studies for the blood loss and for the postoperative pain reduction, and a limited response or study for the postoperative function. So I'm going to move to the next slide, talk about some of the details. Under the pain portion of this, there were a couple of high-quality studies and another moderate quality study that showed decreased pain in the no tourniquet group, in the very early post-operative period. And that was not significant after 4 days and 8 weeks. So not a lot there. On the function side, one high-quality study showed better quadricep function in the no tourniquet group, but an equivalent HOOS-KOOS or Oxford knee scores on range of motion. KOOS is next. One moderate quality study demonstrated better knee KOOS subscores and early range of motion to week 8 postoperatively in the no tourniquet group. So at that point, the differences became statistically insignificant. So the takeaway here, some key considerations, things that I have noticed from being in hospitals week in and week out and speaking with surgeons and administrators and OR managers, really there was a push to use or to decrease tourniquet use for knee replacement for a period. And subsequent to that, here recently, I have seen that has subsided. I will note that there is an exception. When we do work in Europe, there are still a number of hospitals and surgeons who really push for that still over in the European. But here in the U.S., that no tourniquet use has subsided. So I find that pretty interesting. All right. Well, you guys did a great job on the first poll. We're going to keep it going. So the next poll question I'd like you to think about and to respond to, as you can see there, are you currently using antibiotic bone cement on all total knee replacement cases? And you can see yes, no, I don't know, or only on high-risk patients. So starting to see some results coming in. We'll give it 5 more seconds. Expand it so I can read the results. And we will close it now. Perfect. Okay, thank you very much. All right, so this is interesting, evenly split. Waiting, we've got one more response or two. We want to count. All votes are important. We're going to count them all. There we go. So a couple of them did change, actually. Very good. All right, so you can see yes, 3 of 19 looks like, so that's about 16% of you responded that antibiotic cement was being used on all total knee replacements. No, again, evenly split. Another 16% responded no. I don't know, 32%, so this is a good area to start thinking about. And then no, only in high-risk patients, that's 11%. So if you can see those poll responses, this actually, as I look over these responses in this limited group, sample size, I should say, I would say this reflects what I'm seeing when I'm spending time out in ORs. That there are some surgeons who want to use it all the time, and others who are just using it for their high-risk patients. So very similar to what we just saw there. So what did the AAOS report have to say? Limited evidence does not support the routine use of this type of cement on primary knee replacements. And that's the strength of that is limited evidence. But let me talk about the details. So just in summary, there's a lot here, but the first bullet point shows that there was shown a benefit to using antibiotic cement for diabetic patients when antibiotic was added to the cement. And I want to point out that this study was performed on operating rooms without modern features. So to control specifically for the antibiotic was difficult, but it's something that we wanted to note there. On infection, one moderate quality randomized, you see study was done that showed for revisions, the rates went down when vancomycin was added to the cement. And then a large Canadian registry retrospective was looked at, looking at 36,000 patients, found absolutely no difference. So you can see it's mixed results, but here's what I want to point out as a key consideration. I have encountered many surgeons who feel very strongly about using antibiotic cement on everyone. It's a strongly held belief that they have, and they want to continue to do that. That's usually an indication that they have concerns about, as I've said, the hospital's ability to manage infections. So your takeaway, I believe, should be it's important to facilitate a conversation with those individuals so really each party can understand the motivating factors. Why does a surgeon want to use antibiotic cement? Why do they feel like their patients, even though they don't have any comorbidities, have an increased risk of infection, and so therefore they want to use that type of cement? So I would encourage you to look in that direction. All right, moving on. Now we're going to talk about cruciate retaining arthroplasty. Strong evidence. Here's a 4-star rating here. It's strong evidence supports absolutely no difference in outcomes or complications between the PS and cruciate retaining arthroplasty designs. So let's move into the details. Let's talk first about pain, motion, and pain function and PROMs, patient-reported outcomes. Meta-analysis included literature was unable to show any difference between those two types of procedures with regards to complications, pain, function, or patient-reported outcomes. Let's talk about range of motion. There was one high-quality prospective study that evaluated those outcomes in range of motion in consecutive patients having bilateral arthroplasty, had one posterior stabilized, or PS, and one CR implant. And they found equivalent scores, but statistically improved range of motion in the PS group. And lastly, another high-quality study failed to show improved kinematics or improved clinical outcome with the PCL retention and highly conforming mobile bearing total knee replacement. So a lot going on there, but essentially this practice seems to be dependent on the surgeon preference. There are surgeons who feel they get better range of motion, less pain, better function with sacrificing the PCL. It's important to facilitate, again, this goes kind of back to what I said before, facilitate that conversation so each party can understand the motivating factors of why a surgeon might want to perform the procedure this way. Next thing I want to talk about is the bilateral TKA. You can see this is a limited evidence to support simultaneous bilateral TKA for patients 70 or younger, and you can see the ASA scores as well. The strength of recommendation is limited, 2-star, but I thought it made sense for us to talk about today. Just to touch on this, complications, there's one low-quality retrospective comparative study that evaluated this in consecutive patients had bilateral simultaneous total knee, TKA, that met the criteria for that inclusion. They found equivalent complications amongst patients who were not elderly. So essentially, you know, you put all this together, and bilateral TKAs are often done for the benefit of the patient. The patient is traveling great distance. They don't want to have a life-disrupting surgery done twice with the recovery. They want to get it done all at one time. There's also efficiency benefits to the hospital and the surgeon. However, and this last bullet point is important, it is important to understand your reimbursement picture at your hospital. You need to partner as a hospital, partner with your surgeon to ensure that it makes sense for your surgeon as well as for your hospital. That is the main takeaway from that particular study. Lastly, I'm going to touch on the patient-specific instrumentation, or PSI. There are 2 good quality studies that indicate for pain and function and for transfusions and complications that there is limited or no support to use the PSI for those particular categories. Let me talk about some details here. Under pain, there's 2 good studies that showed there was no difference in pain scores between the patient that got the PSI cutting guides and patients who got the conventional instrumentation. Both of them found no difference in knee society function scores and or WOMAC scores. So pain, there doesn't seem to be any difference there. For blood loss, there was an indication that there was some improvement in blood loss in patients who got PSI, but there was no significant clinical impact when compared to conventional instrumentation. They found 3 moderate quality studies and another study found similar results with no significant difference between both treatment groups. So I think that what the AAOS can say is for pain and for blood loss, there is no significant or statistical difference between using PSI and conventional. Again, key considerations, many hospitals, the surgeons, they're using PSI for better planning and efficiency, not so much for the other 2 categories that I spoke about. So if this is the case with your hospital or with your surgeon, critical to success is when all the members will leverage the system, the PSI strength, and when I say that, I mean the material handling, the planning, the perioperative, intraoperative reduction of time, and pickup of efficiency. It's important that all those things, all those parties come together to really leverage what the key benefit is for using PSI. All right. So that's what I wanted to cover with the perioperative. I'm now going to turn it over to Luann Waldron, who's going to talk to you about the care continuum.
Thank you, Tim. We're now going to move into the care continuum recommendations, and we're going to start with a polling question. So, is your hospital currently using tranexamic acid on your total knee replacement patients? It's yes, no, or I don't know. Wow, I love this result. 60% of you are reporting that you are using tranexamic acid, and none of you, 0 for no. A couple of you are not sure whether your hospital is using that or not. Okay, well, let's look and see what AAOS gave us regarding tranexamic acid use. So we're going to look at, this section is going to be our strong recommendations, and they did come out with 7 strong findings. So the first one on our list actually is the TXA, and certainly they saw, you know, in patients with no known contraindications, treatment with tranexamic acid did decrease postoperative blood loss. It reduced the necessity of postoperative transfusions. And that was pretty dramatic studies that they saw. You know, as much as their study showing 52% reduction in blood utilization rate. So definitely been a dramatic decrease in the rates in using a hospital. So I'm sure you all have experienced that as well. Another strong recommendation from them came as BMI as a risk factor. So the statement was obese patients have less improvement in outcomes with total knee arthroplasty. And they really looked at 4 high-quality studies. And remember, when we talked about what it was they looked at, they needed to look at least 2 high-quality studies for them to be able to give a recommendation either for or against their finding. So they looked at 4 studies with BMI. And really what happened first was 2 of the studies said, no, there's really no difference in complications. 2 of the studies said, oh yeah, there is a difference. So those 4 studies kind of negated each other because one said one thing and another one said the exact opposite. And they did see within those studies that they were showing decreased function in their outcomes. So, I think that this leads us to think that we definitely need to look at determining our patient selection criteria. I think you may be seeing a lot of your surgeons doing that nowadays, looking at those BMI limits. And if you're not going to look at limits, which some surgeons don't, I think you really need to optimize those patients as best you can prior to doing the case. And a third strong recommendation came surrounding the periarticular local anesthetic infiltration. And the finding was that the periarticular local anesthetic infiltration is more effective when compared to a placebo in total knee to decrease that pain and opioid use. And what they looked at, they compared the PAI to placebo, which was basically just saline. And what they saw was they did see some improved function. They saw lower opioid consumption. They saw increases in their patient satisfaction, and they saw lower pain scores. So definitely a strong recommendation. The other thing that they tried to do, but we really were unable to, is they tried to make an attempt to compare the periarticular injection to the peripheral nerve block, which we're going to talk about here shortly. And they really just were not able to do that. And it mainly came down to when we look at the peripheral nerve blocks and the periarticular injections, there were just too many differences. The PAI has infiltration can be different, the solutions were different, the amounts were different, so they really didn't have enough information to give any recommendation regarding the 2. But certainly those periarticular injections have become an important part of the best practice in the multimodal pain protocols for knee replacement. Drains is another strong recommendation from AAOS. So their statement was that the evidence supports not using a drain with total knee replacement because there really was no difference in complications or outcomes. And they really looked at 4 really high-quality studies, and they looked at a number of things with drains versus not drains. They looked at things like VTE, infections, swelling, blood transfusions. Did the patient get a hematoma? They looked at range of motion, length of stay, pain or reoperation. They really only had a couple studies that did show some increase in transfusion rates when physicians were using drains. So, the consideration is really what we're seeing is those large high-volume best practice centers are really not using drains anymore, and they really are having those positive outcomes without complications, which really correlates with what the surgeons saw when they looked at the research. And then lastly, the one that I mentioned earlier, the peripheral nerve block. So really looking at peripheral nerve blockade for total knee arthroplasty, does it decrease postoperative pain and opioid requirements? And that is exactly what they did see. They looked at really 7 high-quality studies, and they found that it did significantly lower their pain scores and their opioid requirements. Some of the studies even showed an improved range of motion when they saw these patients. So key considerations for the peripheral nerve block, definitely we're seeing it, but I think we're starting to see an increasing frequency of the quad-sparing blocks, such as the saphenous nerve block, and really starting to move away from those femoral nerve blocks, which we all know can cause an increase in the risk for fall because of the quad weakness. So let's go to another polling question. Are you currently using CPMs for your total knee replacement surgeries? Okay. I'm liking those results as well. So we're seeing 15% of you still using CPMs, 45% of this group not. One of our respondents said they didn't really know whether your hospital was using CPMs or not. So let's look and see what did AAOS tell us about CPM machines. So again, we're looking at a strong recommendation. CPM after knee arthroplasty does not improve outcomes. And this was very interesting to me as I got a chance to look at it, because I think we all know that we're starting to see less and less use of CPM, but they looked at 7 studies with strong quality, and really they found that in all of those studies, surgical outcomes for those that use CPM were not better than those who did not use CPMs. They also looked at things like quality of life with those that use CPM. There was no difference. They also looked at physical therapy with CPM versus physical therapy without CPM. They found no benefit in functional outcomes or range of motion, and some of those patients were using that as much as 17 days post-op, so they were going home with their CPM as well. So certainly there are numerous studies to show that CPM does not improve outcomes. We know that early mobilization, pain control, the use of our multimodal approach, and those shorter lengths of stay all lead to our quicker patient recovery and really are eliminating the need for this modality. And probably the most interesting thing that I took away from the CPM recommendation was that they felt that there did not need to be any future research needed for routine use of CPM. There is enough research out there at this point that they really are recommending that CPM is not improving outcomes. And then the last strong recommendation came on postoperative mobilization and length of stay. So rehabilitation started on the day of the total knee arthroplasty reduces length of hospital stay. So as they looked at that, they really only had 2 high-quality studies that they looked at, and those really were, that's the minimum number that they looked at. And so they looked at those that started that PT day of surgery versus those that were delayed, and most of the time we're talking about the day after surgery. So those studies did show them that those were seen on the day of surgery really did end up having a shorter length of stay. Their pain was reduced. They had improved physical function. And by that I mean their balance, their muscle strength, their range of motion. So I think, from a consideration point, we certainly can see that increased frequency of physical therapy and ambulation on the day of surgery does allow these patients to go home sooner and give them improved physical functions.
Thank you, Luann. We're going to move to another polling question. Give me 1 minute to see the question. Are you currently having PT see your total knee replacement patients on the day of surgery? Yes, almost all of the patients are seen. Yes, but it's not happening consistently, or no. Let's see what these results show us. So it looks like the majority of you are having physical therapy start day of surgery, but it's not always consistent. Some of the key factors that we see that limit some consistency is the ability to get them up from the OR, as well as the physician's preference for choosing physical therapy. So we see that 40% are at yes, and another 15% are it's not happening consistently, and 5% do not have physical therapy the day of surgery. So let's see what AAOS recommendations have to say. We have moved from some of the strong evidence that Luann has shared to moderate evidence. And let's remind ourselves what moderate strength recommendations mean. That means there's evidence from 2 or more moderate quality studies with consistent findings, or evidence from one single high quality study for recommending for or against the intervention. So as we look at postoperative mobilization on pain and function, there were 2 high-quality studies that investigated the effects of starting rehabilitation on the day of surgery compared to delaying rehabilitation for 24 hours. The first group that compared the studies for the first 24 hours against a control group, they found that the group who started rehabilitation within 24 hours had fewer days of hospital stay, reduced pain, and improved physical function. So these are all benefits that we continue to strive for, improving outcomes with shorter length of stay. So although it's moderate, those were some pretty good findings to share. So as we look at chronic pain as a consistent factor, there was one moderate quality paper that used low back pain as a form of chronic pain and demonstrated less good outcomes, and another moderate quality paper that showed less good outcomes after total knees for patients, and those patients had multiple joint and or spine pain. The 2 retain a moderate quality of evidence, leading to the recommendation that moderate evidence supports that patients with select chronic pain conditions have less improvement in patient-reported outcomes with total knee arthroplasty. What we see with hospitals that are really paying attention to chronic pain, they believe that it's impacting the outcome. And in order to facilitate a conclusion is they are working to have the hospital collaborate with the surgeons and anesthesiologists to determine that solution, both preoperatively and postoperatively, to ensure those patients with chronic pain have good pain management. So as we look at diabetes, again, this all falls under the moderate strength. You know, 20% of patients that have a total knee arthroplasty typically have diabetes. So I think this is an important one for us to evaluate. There's one high-quality paper that showed a higher rate of complications and an increased risk of revision surgery for diabetics after total knee arthroplasty. Since it was only one high-quality paper that was evaluated, the strength remains at moderate. So it's important to look at what you are doing for your patients with diabetes and facilitate risk reduction strategies to reduce those risks of complications. Many hospitals are including that in their preoperative education as well as postoperative risk reduction strategies. The second study was looking at the delay of total knee arthroplasty. And there was one high-quality study that addressed the question of worsening of outcomes or an increase in complications on delayed cases of total knee arthroplasty, comparing to those without a delay after having failed non-surgical management. It evaluated the effects of waiting time on health-related quality of life, the knee pain, and physical function. The study also addressed the use of cost and medication of the patients awaiting total knee arthroplasty. So while they were waiting for surgery, how much did it cost just in pain management alone? Those in the short waiting time group had higher weekly cost of medication at admission and reached better quality of life 3 months after operation. So one thing that we have seen hospitals do is implement a shared decision-making model. That can ensure the patient is aware of their timeline of the decision-making for surgery against their short-term and long-term results for outcomes. The last one listed here on the moderate studies is looking at cryotherapy devices. There were multiple studies that went into this, and they were looking at cryotherapy sleeve as well as compression devices. And some of this information that they looked at is really multifactorial, looking at unicompartmental knees as well as randomized between epidural anesthesia. So there was a lot of variables going into this type of study. What they were looking for is the narcotic consumption in the high-level study that contradicted the findings in the relevant moderate-level function studies that were not internally supported. So there was a lot of conflicting information in the studies that were utilized with cryotherapy. So there's still a moderate strength of utilizing cryotherapy as a non-pharmacological option. But what we have seen several hospitals evaluate cryotherapy, whether it's with compression or ice alone. I think what's important is that you look at consistency among your physicians and determine the impact on the mobility for the patient as well as the pain medications or narcotics that are used. You know, there's so many different factors in looking at this. Cryotherapy, it's hard to single out one critical factor, and that's what these studies essentially showed. So just ensure that your patients are consistently getting provided with your cryotherapy choice, and ensure that it does not negatively impact their use of narcotics or mobility. So the next thing that is evaluated here that gets a moderate strength is neuraxial anesthesia, or epidural or spinal use. They've decided that neuraxial anesthesia could be used in total knee arthroplasty to improve select perioperative outcomes and complication rates compared to general anesthesia. And there were 6 high-quality and 3 low-quality studies used to evaluate this anesthesia and this recommendation. 2 of the high qualities and 1 low-quality study demonstrated significantly lower rates of DVTs compared to general anesthesia. And the 2 high-quality studies did not utilize any form of preoperative prophylactic anticoagulation. The low-quality study utilized postoperative aspirin therapy alone. Neither study used warfarin or low molecular weight heparin as part of their post-op DVT prophylactic regimen. There were 4 additional low-quality studies that demonstrated significant reductions in overall post-op complications with neuraxial anesthesia. Those were including reductions in blood transfusion rates, pulmonary compromise, pulmonary embolism, pneumonia, mechanical ventilation rates, acute renal failure, and infectious complications. 2 high-quality studies demonstrated improved short-term functional outcome after neuraxial anesthesia, and 1 demonstrated short-term range of motion, flexion, and ambulation compared to general anesthesia. Another low-quality study demonstrated a significant reduction in 30-day mortality in patients undergoing the neuraxial anesthesia to compared to general anesthesia. So you can see where they get a moderate strength here. Again, it's really important to have a defined care protocol for your organization. Define criteria for use of which type of anesthesia from a clinical perspective should exist, and also understand the impact of the day of surgery. You know, we've seen anesthesia, or looking at nausea and pain control as 2 indicators for looking at mobility with the use of different anesthetic types. So now we're moving to moderate and limited type strength of recommendations. The next 3 recommendations all revolve around post-discharge therapy, and they broke their recommendations into 3 categories, 1 which is moderate and 2 of which are considered limited strength. 1 high-quality study and 1 moderate-quality study investigated supervised exercise programs started after hospital discharge compared to no or minimal exercise programs during the first 2 months of surgery. We can say that is very atypical for what we see, not doing any exercise, at least having the patient do an independent home program as compared to nothing at all. The first comparative group of patients with post-op who received a home exercise program of 8 weeks, 3 times a week, and it consisted of lower extremity strength training, to a group who did not receive the supervised exercises. The exercise group had significantly better physical function and knee flexion and extension range of motion. The second comparative group of patients with bilateral total knees who received a month of intensive supervised rehab 2 times a week for an hour, to a control group who received supervised rehabilitation once every 15 days. The intense supervised group had less pain and stiffness and better balance and physical function for the control group than compared to the control group. And remember, that was with bilaterals. 2 high-quality studies and 1 moderate-quality study investigated supervised intensive exercise programs starting 2 or more months after surgery compared to no or less exercise. And the first compared a group who performed functional exercise supplemented with balance training to a group who performed functional training alone. So it really goes into the efficacy of what types of therapy is being recommended. So when you look at the outcomes, they were very similar. So it looks like the moderate is stating that early stage supervised exercise program impacts function. A supervised program during the first 2 months after total knee also decreases pain. And then late stage postoperative supervised exercise program had a limited result. And when we're looking at ensuring that your program has consistent postoperative plans, you need to establish that during the hospital stay. So determine what you are suggesting your patients receive postoperatively and collaborate with those home health and outpatient rehabilitation agencies. One thing to look at is the utilization of patient-reported outcomes and compare that based on your physician preference and postoperative care plans. So a lot went into those determining the post-op plan for rehabilitation. Let's go to our next polling question. Are you currently evaluating your patients preoperatively for risk factors and/or risk stratifying for your patients? Answer is A, yes, we are optimizing our patients. B is yes, but we don't do anything with it, meaning we evaluate the patient, but we don't have execution plans in place. And then C is no. We'll give you a few more minutes to look at that. And we can close that poll, Jeanette. You know, this is probably, out of all of the questions we've seen, the one with most variance amongst the group here listening. So there is about 40% of you are looking at risk stratifying your patients preoperatively, which is a great thing. But of that 40%, 20% of you, or half, do nothing with that information. And I would say that's very consistent with what we see when we evaluate programs across the country. If hospitals have made a step to put risk stratifications and risk reduction evaluation in place, they don't always do anything with that information and share it with the postoperative care providers. So let's look at some of AAOS's recommendations that are of a limited strength. We're going to go through depression and cirrhosis first. When we look at what the literature shows, it's about 12% of the patients who have total knee arthroplasty have depression. And one moderate quality study and one low quality paper demonstrated less good outcomes in patients with anxiety or depression. There only being one moderate quality paper, the recommendation made was that limited evidence supports that patients with depression and or anxiety symptoms have less improvement in patient-reported outcomes. I would say that is probably counterintuitive to what I have heard from a lot of surgeons, but this really helps us understand, based on the literature that currently exists, there's limited evidence to support that. So making sure you have processes in place to consider depression as a risk factor is certainly recommended. The second one is cirrhosis or hepatitis C. Given that the liver is a target organ for hepatitis, those risk factors were grouped together. One moderate quality study demonstrated higher complication rates after total knee arthroplasty in patients with cirrhosis, and another lower quality paper demonstrated the same in patients with hepatitis C. So there is limited evidence that supports the patients with cirrhosis or hepatitis C are at risk, higher risk for complications. But that doesn't mean you shouldn't put risk reduction strategies in place. If you're evaluating that patient and considering them for surgery, certainly ensure that all of the care providers understand the risk for this patient population, at least to identify those risks, even if the complications are not occurring. And the last is preoperative physical therapy, or as some people are calling it, prehab. There were 4 high-quality studies and 4 moderate-quality studies comparing preoperative structured exercise programs to groups receiving no exercise, placebo exercise, or education. In all of these studies, there was variation existing among the exercise programs. They included functional training, resistance training, flexibility, and step training. The length of the program also varied. The result was there is limited evidence to support preoperative physical therapy. So that's from a practical and a functional standpoint, But we also know that with Medicare recommendations and to ensure that you are qualified for a total joint replacement surgery, oftentimes you have to receive structured preoperative rehabilitation. So it's our responsibility at the hospital to ensure that the preoperative rehabilitation visits, which may include prehab, doesn't impact your ability to provide postoperative care. You know, we've spoken to some hospitals that they're only left with maybe 6 visits postoperatively because of Medicare requiring preoperative rehab and then their prehab visit. So it's important to understand that and the desired outcome during the hospital stay. So are you utilizing prehab as a way to better educate your patients to those postoperative exercises? And if you're unable to do prehab that way, ensure that you're getting that information through your preoperative education. So that was a lot of information, a lot of technical information, if you will, because it was our responsibility to provide you with a deeper dive into the AAOS recommendations. So now we'll open it up for questions. So the one question that has come up, are most hospitals doing group physical therapy? I'll give an answer then. Luann, welcome to chime in. We still see many hospitals providing therapy to multiple patients at once. Where there is discussion is whether or not everybody needs to be on post-op day 1 surgery all doing the same thing. So there's different opinions of what group therapy is. As length of stay has reduced, I have also seen a reduction in the approach of everybody has to be post-op day 1 in the morning in the same therapy room versus just making sure there is the opportunity for patients to collaborate with each other in a dynamic room setting as compared to room-based therapy. Luann?
Thanks, Michelle. I would really agree with what Michelle is saying. We do see a fair amount of hospitals still coming together in the group setting. You know, we do need to be cognizant of the fact that they may not all be at the same level, so we may have to have ways that we individualize. But certainly we do see some benefits from group therapy, like the camaraderie, and also just the fact that it helps them say, gosh, my neighbor there had knee surgery the same day as me, and they're bending farther than I am. I'm going to push myself further. With that being said, you know, what is the future of the length of stay of total knee patients? We're seeing some of these patients moving into the outpatient setting, which obviously our group therapy would not be something that we'll be utilizing, but I think we're still seeing a fair amount of hospitals having the group therapy room and bringing those patients together. It also gives you an opportunity to potentially do other things with those patients, such as maybe some discharge type instructions that would be similar to all patients.
Okay, the next question that we have is, do the guidelines address use of urinary catheter and the early discontinuation if used?
The clinical practice guidelines that AAOS came out with did not address the use of the urinary catheter and early discontinuation if used. I mean, from a perspective, I think we are seeing, certainly we know our original guidelines with CMS was that we needed to, if we're using catheters, we need to remove them by post-op day 2. And you know, most of our centers are really pushing that to post-op day 1. And then at this point, really, a lot of centers are not putting the Foley catheter in to start with, and obviously that can help us eliminate a lot of potential post-op complications. So I would say from a perspective of our partners, we're seeing more facilities not putting the Foley in at all for total knee replacement.
I think that was a great question that was asked, because we are oftentimes asked that question. Where we see urinary catheters typically required, it's not from the orthopedic surgeon, but it's from anesthesia and their ability to evaluate fluid control. So that's probably why it didn't appear in AAOS's guidelines. To Luann's point, I would wholeheartedly agree. We have seen a propensity to reduce the use of urinary catheters. what most anesthesiologists will say is that is time dependent based on how quick the surgery occurs. So if it's under 2 hours, then oftentimes they're feeling more comfortable without putting a urinary catheter in. As another point to note is the Joint Commission, when they are doing the disease-specific care certifications, that is something that we have seen more of their reviewers evaluating in hospitals, and they are looking for more hospitals migrating away from urinary catheters or taking them out sooner, like Luann had mentioned. So one comment was asking whether or not ice was used, straight ice was used in that evaluation of cryotherapy, and it was ice as well as cryotherapy with the compression device. So unfortunately, there was limited recommendations for that.
Another question, are hospitals letting their patients shower right after surgery? That's a great question. Obviously, that was not addressed in the AAOS guidelines. I think from my perspective, I'm seeing either side of the equation. It really tends to be surgeon-specific. A lot of patients are allowed to shower, and they're actually doing that with occupational therapy prior to leaving the hospital, but it really is going to be surgeon-specific. What type of dressings are hospitals using post-op total knee? Again, that wasn't addressed with AAOS and their guidelines, but I think we definitely are seeing a move away from our old Jones dressings, which were the big, 4x4s, lots of gauze, lots of cast padding, many ACE bandages, and we are seeing smaller and smaller dressings being used. Certainly, there's another question that's popped up, and it says, again, for post-op, but are they silver impregnated? We are seeing those products being used, and there are a number of different ones out on the market. I certainly can't specifically recommend to you which one is better than the other, but it's a whole conversation around the how your surgeons feel. It almost goes back to that showering as well. Are they comfortable with the wound getting wet? Are they comfortable with daily dressing changes? These longer use silver impregnated, just in case some of our listeners aren't familiar with that is, those are put on and they are left in place for many, many days. So they're left in place during the hospitalization and then also at home. And the idea behind that is trying to prevent surgical site infection, and there are some studies that are showing that the silver impregnated dressings are going to help reduce bacteria.
That was great, Luann. And I think it's interesting, some of these questions that are so practical to our listeners weren't addressed. Quite honestly, I think this is a big step to have this level of evidence be provided by AAOS. So much in the United States has been more consensus-based and what we see best practice, versus now we have the ability to at least reference this document, which provides you with some supporting evidence when you're looking to reduce variability amongst your physicians and your programs.
I think the other thing we need to keep in mind from these guidelines is, we have strong recommendations, moderate recommendations, and then those limited recommendations. I think that you will definitely see more research being done and potentially some newer recommendations come out when we're looking at moderate and limited. They are going to continue to look at those particular pieces and potentially change their recommendations. From a strong recommendation, I don't think that we'll see changes. So I think it's important for your hospital to review those recommendations from AAOS, and especially those 7 strong findings. Review that and see where does your program land in terms of those 7 strong findings. And, I think that this would be really good beginning discussions with your physicians if you aren't potentially following the recommendations, those strong recommendations that AAOS provided.
So thank you, everybody, for your attention to this topic. Our goal was to review almost 700 pages of documentation and synthesize that into some critical factors that we typically are questioned as well as we're trying to drive consistency in hospital programs. So certainly that information is available at that www.orthoguidelines.com. and we can make sure that we get that information out to you. If you have any questions or aren't able to find it, just make sure that you email either somebody that you work with within Accelero or can send a note to Jeanette as well. We'll be able to provide you with that. So we hope you enjoyed today's conference. If there is anything else that you would like to recommend for a topic in the future, please contact Jenna. Jenna.desormier@accelerohealth.com. We'd love to hear from you. Thank you.